Good morning, one and all. I am Dr. Katta Bhavana, Senior Resident General Surgery students. Today, our topic is management of hand infections. And before going to the management of hand infections, it is important to know the anatomy of the hand and different types of organisms responsible for the hand infection. Coming to the anatomy of the hand. Anatomy of the hand consists of the bones which forms the hand or the metacarpal bones along with the phalanges, and there are intrinsic muscles of the hand, and there are tendons of the forearm muscles which extend onto the palmar surface of the hand. So the intrinsic muscles of the hand which forms the hypothenar eminence forms the opponent's distal minimi, flexor distal minimi, abductor distal minimi, and the thenar muscles are flexor pollicis brevis, abductor pollicis brevis, and opponent's pollicis. Apart from this, there are lumbricals and dorsal interossei and palmar interossei adductor pollicis. So these are the different pictures which were showing the anatomy of the hand and the intrinsic muscles of the hand. You can see there is a dorsal view of the hand which is showing the dorsal interossei which are bipinnate in origin, and the palmar view which is showing the palmar interossei which are unipinnate. Coming to the arterial supply of the hand has a superficial palmar arch and a deep palmar arch which supply the blood to the hand, bones, muscles, and also the tendons, including the soft tissues. So the superficial palmar arch is formed by the ulnar artery and the superficial palmar branch of radial artery. And this gives off the digital arteries which supply the digits. Apart from this, there is a deep palmar arch formed by the distal portion of the radial artery which anastomoses with the deep branch of the ulnar artery. This forms the deep palmar arch which supplies the bones muscles. Coming to the venous drainage. All the veins, metacarpal veins, they drain into the cephalic and basilic veins, which extend into the forearm. Nerve supply, it is supplied by ulnar nerve, median nerve, and radial nerve. Coming to the common hand infections, these are acute paronychia, chronic paronychia, phalon, flexor tenosynovitis, deep space infections. Deep space infection is again with palmar space infection, space of corona infection, and the hypothenar and thenar space infections. The main treatment principles are, first we need in order to all these infections will have an abscess which needs incision and drainage. So before placing the incision, we need a tourniquet control to prevent exsanguination and to eliminate the limb, to tourniquet control and elevate the limb to exsanguinate the limb, and then long and extensive surgical incisions for adequate drainage of the purulent material, and incision to minimize exposure to the blood vessel, nerves, and tendons, and avoid longitudinal incision across flexor creases. And excess of necrotic tissue, everything should be debrided, and the debrided tissue should be sent for gram staining, aerobic and anaerobic, and fungal and microbacterial stains, culture sensitivities. And after the placing incision, thorough and debridement, thorough irrigation has to be given, and wound management should be that wound should be left open. Negative pressure dressing should be applied, and there is no urgency in closure of wounds. If inadequate drainage wound, if it is closed primarily or delayed secondary, there can be recurrence. And delayed primary closure or secondary healing is usually the wound management. Next, postoperative care is frequent dress changings for the open wounds, alternative dress changings in the negative pressure therapy, early motion to avoid tendon adhesion and stiff joints. Multiple debridements may be needed, and if unable to eradicate infections, then amputation might be necessary. Empirical antibiotics are started initially. After culture sensitivity is obtained, the sensitive antibiotic should be changed to. And most common infection types are cellulitis. These are organisms responsible for staphylococcus and streptococcus. And the initial empirical antibiotic therapy is first generation cephalosporin or penicillins. When coming to paronychia or deep space infection, phalon, these are all abscesses which are usually common by the Staphylococcus aureus. MRSA is commonly seen in community. So to cover this MRSA, we empirically start IV vanco or Clinda or oral cotrimoxazole, clindamycin or doxycycline. Next, coming to flexor tenosynovitis. The common organisms are Staphylococcus and anaerobic organisms, and the polymicrobial origin has a worse prognosis. So IV ampicillin sulbactam with cefotaxime or oral amoxiclavulanate plus clindamycin is given. Coming to human bite, Staphylococcus, Streptococcus, Eikenella, anaerobic organisms. These are the common organisms. So, in order to cover this, the spectrum of antibiotics given are ampicillin sulbactam with cefotaxime or amoxicillin fluoroquinolones with clindamycin. And animal bite, the most common organisms is Pasteurella multocida, Staphylococcus, Streptococcus. For this also, ampicillin sulbactam with cefoxitin or oral amoxicillin with clinda, or for patients who have penicillin allergy, fluoroquinolones with clindamycin can be given. And suspected community-acquired MRSA, IV vanco and clindamycin or oral cotrimoxazole clindamycin, and suspected hospital-acquired MRSA, vancomycin, linezolid, or daptomycin should be given. In case of necrotizing fasciitis, Streptococcus or polymicrobial infection are the most common organisms. So, broad spectrum beta-lactams with vancomycin with clindamycin should be given. And gas in soft tissue usually involves Clostridium perfringens and polymicrobial organisms. These are usually seen in diabetics and IV drug abusers which are immunocompromised. High dose penicillin plus clindamycin or broad spectrum beta lactam antibiotics plus vancomycin plus clindamycin is given. Next, coming to the common types of hand infection. These are acute paronychia. In acute paronychia, it is the most common infection of the hand. It involves the soft tissue fold around the fingernail, which can be seen in the picture to the left side. So the disruption of the barrier between the nail fold and the nail bed usually introduces the bacterium. And Staphylococcus aureus is the most common organism. And erythema, there will be epineural fold pus accumulating beneath the epineural fold, which causes the erythema, swelling, and tenderness adjacent to the nail. The treatment guidelines are preoperatively in a healthy individual, no other investigations are required. But if the patient is an IV drug abuser, immunocompromised, or diabetic patient, then laboratory investigation should be done for count evaluating the counts, and radiographs if long-standing infection is present to rule out the osteomyelitis. And post-operative care, 7 to 10 days of oral antibiotics according to the organisms which are present, and early conversion to the sensitive antibiotics is necessary, and daily soaks in a dilute povidone iodine solution, and early finger range of motion to prevent stiffness. And complications are usually failure to recognize underlying osteomyelitis, and when there is underlying systemic illness, like the patient is diabetic but not a known diabetic, so when if it is not diagnosed, then there is a high chance for recurrence and severity of the infection. Next, coming to the management. The management usually includes the elevation and removal of 1/4 of the nail to decompress the perineum. Incision of the perineal fold with, you can see the two pictures. A is showing the elevation of the 1/4 of the nail. Along with that, B is showing the incision of the perineal fold with the tip of the blade directed away from the nail bed and matrix. Here, there are multiple pictures which is showing the management of acute paronychia. And the picture A is showing elevation of epineural fold to expose the base of the nail. And B shows the placement of incision to drain the paronychia and elevate epineural fold with excision of the proximal third of the nail. And C to E demonstrates the elevation of the entire epineural fold with excision of the proximal third of the nail. Coming to chronic paronychia. This is usually seen in the middle-aged women. It is more common in women. And chronically indurated and rounded epineuchium will be present. The risk factors are frequent water immersion, psoriasis, immunocompromised diabetics. And the affected population groups are housewives, bartenders, dishwashers, nurses, and swimmers. The causative organism is usually mixed flora. And coming to management of the chronic paronychia, it is usually eponychial marsupialization. The crescent-shaped incision is 1 mm proximal to distal edge of the epineuchial fold, extending from 3 to 5 mm proximally. The tissue is removed down, but not including the germinal matrix. The nail removal if deformity present. Operative treatment. The alternative approaches are the most commonly done is epineuchial marsupialization. The other treatments which can be done is Swiss roll technique. The Swiss roll technique consists of elevation of the nail fold and inverting the tissue and folding over non-adherent gauze and anchoring with sutures. The sutures are removed within 2 to 7 days. Either marsupialization or Swiss roll technique can be done, and most commonly done is marsupialization. This also includes preoperative workup because social thorough workup should be done, and social history for contributing factors, risk factors, and the common population which are affected. Those all factors should be considered to give occupational rehabilitation also. And laboratory evaluation in diabetics and immunocompromised patients should be done. Post-operative care, 10 to 14 days of oral antibiotics. Oral antifungal medication should also be considered. Daily soaks in dilute povidone iodine solution and early finger range motion. The pitfalls are delayed diagnosis. Sometimes, because it is a chronically indurated wound, it can be a tumor or it can be a cyst, which can be left for chronic paronychia, but in case it is a tumor, so there will be a delayed diagnosis. And unrecognized systemic illness and failure to correct environmental factors will cause recurrence. Coming to Phalan. A Phalan is infection of the distal pulp space. So the anatomy of distal pulp space is more important. It has a closed sac connective tissue framework isolated from the rest of the finger. Multiple vertical trabeculation divides the compartments, the distal pulp space into different septal compartments. The blood supply of the digital arteries run parallel to distal phalanx and gives off a nutrient branch to epiphysis before entering the pulp space. And functions are stabilizing the pulp during the pinch and grasp, and highest concentration of sensory receptors are present in the distal pulp space. So the subcutaneous abscess of the distal pulp of finger is called a phalan. These infections involve multiple septal compartments, leads to compartment syndrome of the distal phalangeal pulp. And Staphylococcus aureus is the most common organism. Clinical feature: severe throbbing pain, tension, and swelling of the entire distal phalangeal pulp. The swelling does not extend proximal to the distal palmar crease because of the septations which limit the spread of the infection. And the risk factors are usually penetrating injury and diabetics. Complications are the distal artery gives off the epiphyseal branch, nutrient branch to the bone, distal bone, um, distal phalangeal, distal phalanx before entering the compartment, distal pulp compartment. So the distal epiphysis will not be affected, but the diaphysis of the distal phalanx can undergo osteomyelitis. And the pyogenic arthritis of the distal interphalangeal joint and flexor tenosynovitis from proximal extension. Complications. The blood supply to the periosteum and diaphysis is compromised more than the blood supply to the skin. This causes the bone necrosis, osteomyelitis, and pyogenic arthritis, and can cause tenosynovitis also. So the drainage of the phalan is that multiple incisions can be given, but avoid incision crossing the fingertips or distal interphalangeal joint of flexion crease. Protect the distal nerves and vessels and do not violate the flexor tendon sheet because it will cause flexor tenosynovitis. And incision made at the maximal site of tenderness. The pre-op evaluation with the mode of injury and any history of diabetes and laboratory evaluation and radiograph to rule out osteomyelitis should be done. Post-operative antibiotics for a week along with the daily change of dressings and finger range of motion should be done. The pitfalls are misdiagnosis as herpetic whitlow and unrecognized osteomyelitis, incomplete decompression of the septa. There are multiple septa in the distal space. So all the septa should be broken and should be drained adequately. And inadequate opening of the flexor tendon sheet while giving the incision can cause septic flexor tenosynovitis and creation of the unstable pulp. These are the multiple incisions which are given. It either a horizontal incision or a longitudinal incision over the pulp space, or a hockey stick incision also can be given, as shown in the figure B. Coming to pyogenic flexor tenosynovitis. Here we can see the flexor tendon sheath is a double wall structure with a visceral layer that is called epitenon and a parietal layer, the adjacent to the pulley system. And it is a closed space. It begins in the palm at the level of metacarpal neck and ends distally just proximal to the distal interphalangeal joint. So it includes the flexor digitorum profundus tendons and the flexor digitorum superficial. The picture showing flexor tendon superficial. Flexor digitorum superficialis tendons, which is crossing the proximal interphalangeal joint and getting inserted into the proximal phalanx. And whereas the profundus tendons are crossing the distal interphalangeal joint and inserting into the distal phalanx. So these are covered by the bursas, the synovial tendon sheath. The first, the thumb finger has its own ulna, this bursa called as radial bursa. This flexor sheath, it is called radial bursa, and the remaining four fingers they merge together and forms the ulnar bursa. Sometimes there can be communication between the ulnar bursa and radial bursa, or they can be separately, as shown in the above picture. These are the common variation. There can be communication between the ulnar and radial bursa, or they can be completely separate. Next, pathogenesis. The closed space infection of the flexor tendon sheath. The purulence destroys the tendon gliding, creating adhesions. This leads to a limitation of the tendon function and loss of motion. And Staphylococcus aureus and beta hemolytic streptococcus and are the most common causative organisms. The risk factors are penetrating trauma involving the proximal interphalangeal joint and distal interphalangeal joint. Hematogenous in cases of disseminated gonorrhea. And the clinical features are, these are called canaval signs of acute flexor tenosynovitis. A semi-flexed position of the finger, and there is a symmetrical enlargement of the whole digit. This is called fusiform swelling. And excessive tenderness limit the course of flexor tendon sheath. And there will be an excruciating pain on passively extending the finger experienced along the flexor sheath, and it is not localized to a particular joint or abscess. Coming to the management is the different incisions can be placed for the drainage of the tendon sheath infections. These are open drainage through mid-axial approach. The figure A, which shows the open drainage incision through mid-axial approach, and figure B, which shows that sheath irrigation with the distal opening the sheath and proximal syringe irrigation. The figure C shows the incisions for intermediate through and through irrigation. Proximal and distal incisions are placed and irrigation is done. And D shows a closed tendon sheath irrigation technique. It is called Navasier's technique. The incisions is placed and it is showing the pus which should be sent for culture sensitivity along with the mid-axial incisions. Preoperative evaluation should include all the blood investigations and radiographical investigations. Postoperative care, IV antibiotics and early range of motion with frequent change of dressings and adequate drainage. This radial bursa and ulnar bursa will extend proximally and will communicate with the space of Bhavana. So the radial bursa is continuation of the flexor pollicis longus tendon, extends from the base of distal phalanx and ends at the metacarpal joint. Ulnar bursa begins at the proximal end of the small finger flexor tendon sheath and lies ulnar to the flexor tendon, which are invaginated by it. The space of Bhavana is a deep space in the distal volar forearm. It lies between the fascia of pronator quadratus and the sheath of the flexor digitorum profundus tendons. The common features of the flexor tenosynovitis is it's rarely occur as an isolated infection and the space of Bhavana infections. This is a rarely isolated infection. Usually the tenosynovitis extends and causes the space of Bhavana infection, and swelling and tenderness will be present in the thenar and hypothenar remnants. And usual causative organisms are beta hemolytic streptococci. Ulnar bursa infection, the tenderness at junction of the distal flexor phase of the wrist and hypothenar remnants. Radial bursa infection, infections, tenderness at the junction of distal wrist crease and thenar eminence, and Parona space infection will cause tenderness and fluctuation in the distal volar forearm, distal flexion in the difficult. Operative management is the incision is used for exposure of proximal tendon sheath, and ulnar bursa and radial bursa, the proximal incision should be a longitudinal incision beginning at the proximal wrist flexion base and extending 5 centimeters proximally. The superficialis and profundus tendons retracted radially. Flexor carpi ulnaris and neurovascular structures retracted ulnarly. Bursa is exposed, opened, and drained. The complications are tendon adhesions, flexion, contraction of fingers and wrist, and restricted motions. Coming to the deep spaces of the hand. The deep spaces of the hand are mid-palmar space, hypothenar space, thenar space. The thenar space and mid-palmar space are divided by the mid-palmar septum, which is the septum extending from the palmar fascia. Three anatomically defined potential spaces lies between the muscle facial planes. These are thenar, mid-palmar, and hypothenar. And there are three superficial spaces also. These are dorsal subcutaneous, dorsal subaponeurotic, and interdigital web space. Coming to the deep spaces of the hand. So their boundaries. Coming to the thenar space. The thenar space dorsally, it is the fascia of adductor pollicis, second volar metacarpal, and first volar intraosseous fascia. And on the volar side, the tendon sheath of index finger and radial palmar fascia. Radially, confluence of the adductor pollicis fascia and palmar fascia at the base of thumb proximal phalanx. And ulnar, it is the mid-palmar oblique septum. And coming to mid-palmar space, it is dorsally covered by the fascia overlying second and third volar intraosseous muscle and periosteum of third, fourth, fifth metacarpals. And volar side, it is the flexon sheath of long ring and small fingers and palmar aponeurosis. Radially, it is mid-palmar oblique septum, and ulnar, it is hypothenar septum. And for hypothenar space, dorsally, it is periosteum of fifth metacarpal and fascia of deep hypothenar muscles, and volar palmar fascia and fascia of superficial hypothenar muscles. Radially, it is hypothenar septum, and ulnarly, it is fascia of hypothenar muscles. The proximal and distal extents are distal extent of all the spaces are deep transverse fascia at the level of the metacarpal head, and proximal extent is the base of the palm. And of these space infections, thenar space infection is most common and hypothenar is extremely rare. Coming to the clinical features of deep space infection, it is most common causes penetrating injury of the hand. In the thenar space infection, there will be wide abduction of the thumb and difficulty in opposition. In mid-palmar space infection, there will be loss of palmar concavity and fingers will be semi-flexed. And collar button abscesses, abduction of the adjacent fingers. Non-surgical there is no role for non-surgical management. There should be an incision and drainage is the management. So drainage of the thenar space. It can be a volar approach and or a dorsal longitudinal approach or a combined dorsal and volar approach. The figure A shows the volar approach along the thenar crease and B shows the dorsal approach. Dorsal approach usually will lead to inadequate decompression. So usually a combined dorsal and volar approach is used. Coming to the mid-palmar space infections. So the incision and drainage for mid-palmar space, it can be a transverse incision in the distal crease or a combined transverse and longitudinal approach or a curved longitudinal approach or a distal palmar approach through the lumbrical canal can be done. Coming to hypothenar space infections, the longitudinal incision can be given to decompress the hypothenar space. Coming to deep subfacial space infections. There are dorsal subcutaneous space infection, dorsal subaponeurotic space infections, and also web space infections. Dorsal subcutaneous space infections, these are extensive area of loose connective tissue is present in the dorsal subcutaneous space. The pus can accumulate over the entire dorsum. The usual common cause is the penetrating injuries, and clinical features, there will be fluctuation in tenderness on the dorsum of the hand with painful finger extension. The drainage is the incision is placed, dorsal longitudinal incisions are placed to drain the dorsal subcutaneous space infection. Coming to dorsal subaponeurotic space infection, it lies deep to the extensor tendons above the periosteum of metacarpal and fascia of dorsal interosseous muscles. The drainage is done, incisions are given along the margins of the extensor tendons. Coming to the web space abscess or collar button abscess. It involves the loose areolar tissue between the metacarpal heads and around the deep intermetacarpal ligaments. It can be seen in the picture that the web space infection of the first web space infection, which is causing the abduction of the second and third fingers. The risk factors are usually fissures in the skin in between the fingers and distal palmar callus. Pain and swelling is localized to the web space and distal area of the palm. Adjacent finger lies abducted from each other. This helps differentiate it from the superficial space infections. The drainage methods, there are different incisions which can be given to drain the collar stud abscess. Either a curved longitudinal incision or a zigzag incision, volar zigzag and volar transverse incision, or a dorsal incision along with any of the volar incisions can also be given for adequate drainage. This clinical image shows the collar stud abscess involving the fourth web space. And the incision is placed and pus is drained, which is taken for the culture sensitivity. And this shows the zigzag drainage, zigzag volar incision, and there is a combined dorsal incision is also given. So dorsal along with zigzag volar incision for adequate decompression of the collar stud abscess was done. The treatment principles of the deep space infections are adequate examination, radiographic investigation to rule out foreign body, because penetrating trauma is the most common cause. And as trauma is the most common cause, fractures should also be ruled out. Long-standing fractures and trauma penetrating injury can lead to osteomyelitis, that also should be ruled out. And MRI is usual tool for identifying the localized abscess. The pitfalls is if there is a delay in the surgical treatment or if there is inadequate decompression, it can cause iatrogenic injury to the neurovascular structures. So these are the different spaces of the hand and different organisms and the causes causing the hand infections, and the management, the preoperative management, postoperative antibiotics, the different incisions for the different infections. The most important is giving the culture sensitivity antibiotics and making sure adequate decompression of the space of the infection occurring space should be decompressed. Thank you.